Good afternoon. Welcome to Grand Rounds. Today we'll be talking about nutrition in the elderly. Dr. KWAKYE, our senior geriatrics fellow, will be presenting. Dr. KWAKYE comes to us from Ghana. He attended Kwame Nkrumah University of Science and Technology in Kumasi, Ghana. He trained at Komfo Anochi Teaching Hospital at the Central Regional Hospital in Ghana. Practiced for 2 years. Then he attended internal medicine residency at Harlem Hospital, which is a part of the Columbia Medical System, in internal medicine. From there, South Dakota was fortunate. He came to Aberdeen. Was up at St. Luke's Hospital as a hospitalist. He joined the geriatric fellowship and has also moved his practice to Vera McKinnon Hospital, where he's a hospitalist. He is in our part-time program. 1 week is a hospitalist, works 80 to 90 hours. The next week is a slack week. He's 40 hours as a fellow. He's doing this for 2 years. He'll be finishing in April and joining our faculty in May. We're very happy to have him as a fellow and as a faculty member starting this spring. I'd like to introduce Dr. KWAKYE.
Thank you for coming. Before I start, I'd like to say thank you to the Geriatrics Fellowship Program for thinking about the part-time track. Not everybody wants to stop work and do fellowship full-time. So for me, it was pretty good because sometimes the week off, you're just at home, you're not doing anything really. So it was a wonderful time to do this fellowship. And I want to thank Dr. Dan Brath, Dr. Brechtelsbauer is not here, Dr. Thano for their mentorship, Dr. Luma Bushin as well for their mentorship. And important knowledge they have acquired over decades. And also being patient with me. When I started the fellowship, I did not have any idea about a lot of things, but it's been good so far. And Marina is not here. She's a program coordinator. She's been wonderful. She makes things happen all the time. Thank you. So to get here as a part-time fellow, it's not been easy. I just thought I was sitting here around 11:30 and I was thinking some statistics. So I've been traveling between Aberdeen and Sioux Falls for quite some time. And I gathered I put about over 15,000 miles up until October just for the fellowship. Just the back and forth, not taking into account the number of miles you also travel in Sioux Falls. And I've burned over 600 gallons of fuel also. And then I think I've spent days and nights, over 200 days and nights, sleeping in different hotels in Sioux Falls. So it's been pretty fun. So I guess today, the reason I chose this topic was, unlike, I don't know about you, but if it comes to nutrition in my older adult patient, I defer everything to the nutritionist. And I just felt that we've heard about everything else to do with the elderly patient, but how about nutrition? So I'm hoping that by the end we finish with this talk, hopefully we can define malnutrition, talk a little about the epidemiology of malnutrition, and then explore some age-related changes in the GI tract, talk about the energy needs of the older adult, and define some conditions, medications, and cultural influences that can affect nutrition in the older adult. How do we screen and assess nutritional status in the older adult? And then maybe talk briefly about some nutritional syndromes in the older adult, and then address broad principles in treating undernutrition. So what is malnutrition? Malnutrition basically is a spectrum. It encompasses overnutrition and undernutrition. And for the purposes of our discussion today, we'll equate malnutrition to undernutrition. So undernutrition per WHO will be defined as the outcome of either insufficient food intake or repeated infectious disease processes. And phenotypically, undernutrition or malnutrition can manifest as being underweight for your age or being dangerously thin when it comes to your height. Why do we have to talk about undernutrition in the elderly? It's kind of important because the honest truth is the population of persons more than 60 years is getting bigger. Whether we like it or not, in 2050, about 1 in 5 of anybody you see in the United States will be more than 60 years of age. The reason why the older adult or older folk, the population is increasing is because of two big factors. The first one is increased life expectancy. This probably is due to the fact that we've done a lot with regards medicine, technology. We're keeping people older. So for example, in the 1900s, average life expectancy for both sexes was about 47.6 years. And then in the 1950s, it went up to like 68.2 years. The most recent statistic we have for the United States is about 78.8 for both sexes, and that's from 2012. So people are living longer, so obviously we will see more problems related to the older adult. Also, family size is getting smaller. When I was growing up, the average family size from where I come from was about five kids, 6 kids. Now it's about 2 to 3. Probably the same for you. And I do not know if it has to do with the fact that the more recent statistic I have is if you're a kid, if you gave birth in 2015, it takes about $233, over $200,000 to raise a kid that was born in 2015. So maybe it's becoming pretty expensive to raise a kid. So maybe that's why we're not giving birth like we were previously. And per the World Aging Report, by 2050, adults who are more than 60 years can be said to live for additional 22 years. So definitely we'll get there with a lot of people who are older. And like we already said, 1 in 5 people in the USA by 2050 will be over 60 years of age. How common is the problem of undernutrition? Prevalence of undernutrition kind of varies depending on the setting you're looking at. But generally for the person who lives in the community, their risk of getting undernourished is less compared to somebody who is in a rehab center or in a hospital. And then if you go through literature, these are some of the percentages you will come across. There are so many numbers, so I try to just kind of group them up. So for people living in the community, it's said that maybe up to about 45%, between 15 to 45% might be undernourished or malnourished. For hospitalized patients, up to half of the people you see will meet that term of being malnourished. And in nursing homes, amazing, up to 85% of persons you see in the nursing home can be said to be undernourished or malnourished. So there are changes that occur in the GI tract. These are physiologic, they are normal, they are expected, but they can affect the way the older adult is able to eat or feed. One of the things I like to talk about is this term you might hear and see in literature is called anorexia of aging. And that just says that as you grow, your appetite just decreases. And there was this group out of New Mexico, they said, well, it decreases, but by how much? So they did a study, and they ought to come out, and they said that, so averagely for men, that reduction is about 25.1 kilocalories per day. And then for women, about 19.3 kilocalories per day. That's pretty significant. Every day, that's how much it goes down. The next thing is there's a reduction in smell and taste as you get older. The evidence is more robust for smell, especially after 50 years of age. And this definitely can impair how you smell food and how you taste food also. The older adult will lose teeth. Salivary production will go down. You need saliva to be able to mix your food in your mouth, roll it into a bolus, and put it through the oropharynx and down into your esophagus. If you cannot produce saliva, it's difficult to form the bolus and facilitate swallowing. Again, there's this mesenteric plexus, we all know from the medical school, from going through med school. It helps with pushing food down the esophagus and into the stomach. As you grow, you lose neurons in this plexus. So once food hits your esophagus, it's difficult to push it down. And so the older adult will have a sense of dysphagia, and if that happens, they will not want to eat like they're supposed to. Also, there's impaired gastric emptying. You eat, you got to move food out from the stomach into the pylorus, into the proximal small intestine, and down. In the older adults, gastric emptying is impaired. And then also there's this phenomenon I like to point out, it's called adaptive relaxation. So what happens is if you ate something and you feel really full, it's because you have a lot of intragastric pressure activating your mechanoreceptors in the stomach wall and telling your brain you're full. After a while, the fundus of the stomach just goes in, so you don't have that distension on the mechanoreceptor, and you feel like I can eat more. Well, in the older adult, this is impaired. The fundus stays distended for a long time, so they have this sense of satiety for a long time. So they eat something small, they don't want to eat anything again. So they can't really eat like they're supposed to. And then, probably due to bacterial overgrowth, decreased acid production, you can have impaired absorption of micronutrients like iron, zinc, folic acid, B12, and calcium, and these have implications as well. And then there's increased transit time in the colon, which can predispose to constipation, and therefore maybe can affect their intake of food. I'd like to also mention this. There's something called a sensory specific satiety. The reason why when you see a buffet like it's set out there, you want to take a little of rice, a little of the salad, a little of the meat, is in your brain, we are programmed to eat a little of something. So when you start eating the rice, your brain can say, well, stop it, eat some of the salad, stop it, eat some of the meat. That is a sensory specific satiety. So you eat some of the rice, like, I want to try this. In the older adult, this is impaired. So they cannot actually have that sense that let's eat some of the rice, some of the meat is impaired. So the older adult will likely eat a more monotonous diet and will stick to what they know all the time. So this has implications, because then you cannot get the older adult to get all the nutrients they need from maybe having like some rice, some meat, some vegetables. So it's good to know about that too. So basically, moving to the energy needs of the older adult, it's important to know that the basal metabolic rate of the older adult decreases with time, and that's because they lose muscle mass. Basal metabolic rate is a function of the lean muscle mass. So if you're losing muscle mass, your basal metabolic rate goes down. And this translates to how much energy you need in a day. If you can remember this number, that for the patient, the older adult you see in the hospital, in the clinic setting, in the nursing home, they might need between 25 to 30 kilocalories of energy per kg per day. So that can help you kind of estimate their energy needs. This illustration I have here, I borrowed from the United States Department of Agriculture website. It's what they're promoting right now. This is for the family member who's concerned about the energy intake of their older adult or dad, mom who's elderly, and want to have a fair idea about how much it is supposed to eat. So basically they say that all these food groups should be represented in the older adult's diet. And if you can't remember the quantity, just split the plate into 4, and then each of these food groups should have a portion on the plate. And then it's good to have some source of dietary products also in a day to kind of provide calcium they need. This is a very good resource. I've used this website multiple times, and for some of us who take care of patients in the primary care setting, it's really good, not only for older adults, even for kids as well, it can help. And then I'll recommend that if you have time, you check it out. It also has instructions about diet, not only in English, in Spanish, and other languages as well. So it's really a neat resource. But for us as clinicians, how much of a prudent diet should an older adult have? Basically, your protein should be this much, about 0.8 grams per kg per day. If your patient is in the ICU, is admitted to the hospital, obviously they need more protein to get well. So about 1.5 grams per kg per day should be good. Fat, up to about 35% of the total energy intake in a day, but we should pay attention to the fact that it should have decreased cholesterol, decreased saturated and trans fatty acids. These are not good. And then for carbohydrate, because that's the primary fuel for the older adult, up to about 65% of total energy needs a day should be good. And I see this come across all the time. How much fiber does the older adult need? So basically 30 grams per day for men and 21 grams per day for women should be good. And we should know that the nutrients we need as middle-aged and young people does not apply to the older adult. Very different. So this is just a few of the micronutrient needs of somebody, say, more than 70 years of age. I just picked these 7 because this is really what we come across. Almost everybody knows we need calcium to maintain, bone health, muscle health, but how much calcium do we need a day? About 1,000 milligrams or 1 gram for both sexes should be good. Potassium about 4.7 grams for both sexes should be good. And then vitamin D, 10 micrograms for both sexes should be good. Fluid needs of the older adult. I guess, again, it's important to know that as we age, changes in the hypothalamus would result in these things I listed. There's a decreased perception of thirst. So the elder adult cannot tell you I'm thirsty like we would. Also, there's a decreased response of the body to changes in your serum osmolality, whether high or low. And then also, the kidneys lose that ability to concentrate urine. So even if the older adult is dry, they will still push out a less concentrated amount of urine. What does this mean? That they are at a higher risk for getting dehydrated. So kind of important to know. If you remember this too, it helps. How much fluids does the older adult need in a day? 30 mils. It's almost similar to the total energy needs they need for a day. 30 mils per kg should help you know how much they need. I want to mention too that diseases that potentially can impair physical or mental ability to recognize and express thirst can result in dehydration. So if a patient comes to the hospital for whatever reason, they can't get out of bed, they're really sick to vocalize that they are thirsty. In the nursing home, they have pretty bad dementia, they have pretty bad stroke, they can't tell you they're thirsty, they will likely be dehydrated. Or if they have some type of psychological program or psychiatric problem and they can't tell you that they're thirsty, they will be dehydrated. So it's kind of important to remember these as well. So there are some risk factors for getting undernourished in the older adult. And these factors, interplay in a complex way to predispose the older person to getting undernourished. So medications, usual culprits, almost everybody's on digoxin because one, either it's congestive heart failure or it's some type of AFib. But one thing about digoxin is it's a potent stimulator of nausea and anorexia in the older adult. I've seen this multiple times. We had a patient who came in with pretty bad AFib. We started the person on, I think it was digoxin, and then she started throwing up and throwing up and throwing up. But everybody was thinking about something else. We just took the digoxin off and she was okay. Amiodarone, another big culprit for altered taste, anorexia, and Flagyl. Flagyl we use commonly for GI infections, for C. diff. It can cause this dysgeusia, which is this metallic taste in your mouth, and can give you a lot of anorexia. Almost everybody is on potassium because they either have some type of congestive heart failure, they're on Lasix, and so you push potassium out, but potassium is difficult to swallow, and that can be a problem in the older adult. They take bisphosphonates for osteoporosis. It's also a big deal, and then we give them NSAIDs. If you don't tell them use lots of water to push the NSAIDs down, it can stick onto the esophageal mucosa and erode it and cause ulcers, and they can have a lot of dysphagia as well. Again, we use Norco or hydrocodone and chronic pain. That can induce a lot of nausea, vomiting, and sedation. And almost everybody gets some type of iron supplementation. That can cause constipation also. So these are things that can predispose the older adult to getting undernourished because they are not eating okay. With regards to medical conditions that can predispose to undernutrition, cognitive impairment, very bad COPD, end-stage COPD with lots of shortness of breath, stage 3, stage 4 congestive heart failure per the New York Heart Association classification, HIV, Parkinson's disease, stroke, malignancy, putting patients in the NPO status. They come to the hospital either for elective or emergent procedure. We keep them NPO forever. After it's done, they're NPO forever because we're waiting for the surgeon to tell us it's okay to start eating. They get undernourished. With regards psychosocial, economic stuff that can predispose the older adult to undernutrition, alcoholism, depression, financial constraints, transportation difficulties. If they cannot get from the house to where they normally shop, it's going to be a problem. If they cannot prepare meals, just like I can't prepare meals, so I'm thinking when I grow old, what do I do? Maybe I have to get a chef to help me out. So, so that can predispose the older adult also to, malnutrition. Social isolation is a big issue. Older adults live on their own, they get widowed, their children have to do other things, so they're just by themselves. Substance abuse, nursing home placement. You go to a nursing home the first time, it's a new environment, the food is different, you don't want to eat anything, you are kind of depressed and sad. Why am I here? That can predispose the older adult to undernutrition as well. And then functional limitation. They can't move around like they're supposed to because they have had a stroke, because they have pretty bad dementia. They will not get where the food source is, so can get malnourished. So we talk about undernutrition, but what are the clinical consequences? Of course, if you don't eat, you're going to lose muscle mass. You're going to lose bone. Physically, you can be impaired, and when you get impaired, you can't move around, you will fall. You fall, you break a hip, your risk of dying, if you're a man, is about 33% from just a hip fracture in a year. And then your wound will not heal like it's supposed to post-op. Risk of wound dehiscence, going back to the OR, increased risk of dying. And then you can have cognitive impairment. Why? If you don't have vitamin B12, you can have dementia. So it's a big thing. And then you have increased mortality also if you're undernourished. With regards to psychosocial economic implications, you're more likely to be hospitalized. You're more likely to go to the hospital again and again and again, and so drive up healthcare costs. Also, if you don't eat and you get undernourished, you risk losing your independence, and then likely you'll be placed in a nursing home. So it's a big thing. And how can you screen for the nutritional status of the older adult? We always taught in med school, it always starts with a good history and physical exam. In taking your history, you just have to focus on trying to unearth risk factors, potential etiologies. We've spoken a lot about stuff that can predispose the older adult to undernutrition. That is what you focus on. Ask them, how much is your mom eating? How much is the older adult eating? It's simple. What are they eating? How often? Who's helping them prepare meals? That will tell you a lot. And then if they have dentures, ask. Is the denture fitting okay? Can you chew with your denture? It's amazing, and you can try it in the clinic. If your patient has a denture, ask them to bite on your finger. You'll be amazed at how weak the bite force is. It's amazing. And then they have to chew stuff, so it won't go well, so we ask them. And then we know that medications can be a problem. We spoke about that. Social history can also kind of let you know what's going on. So trying to explore these areas in your history can help you get a good picture of what's going on. Physical exam. What can point you to the nutritional status or undernutrition in the older adult? Easily pluckable hair, dry scaly skin, cheilitis, dermatitis, corners of the mouth, glossitis, gum that is swollen, bleeding easily, losing muscle, peripheral edema. All these poor wound healing, all these can alert you to the fact that there might be some micronutrient deficiency in the older adult. So important to hone in on the physical exam also. Now that if you've gone through the history, gone through a physical exam, you think this is what's going on, how do you screen using evidence-based stuff to come to a diagnosis? I'll talk on 4 things. How to use a multi-item tool to screen for malnutrition, how to use anthropometrics, the nutritional intake, and lab tests. So with regards to the multi-item tool for screening, I have some of them there, but the first I'll talk about is the Nestle Mini Nutrition Assessment Tool. Pretty simple. It has two forms. There's the short form and the long form. The honest truth is this simple questionnaire has been tested in multiple countries in persons over 65 years of age, and it stands the test of time. You can compare it to anything you have, and this comes on top for patients more than 65 years of age. In preparing for this, I saw like hundreds of papers on this, and each one of them, it beats everything all the time. To use this to screen for a patient, you don't need any lab tests. It's all in the history and physical, and it can tell you straight up in under 15 minutes whether or not your patient is malnourished or is at risk for malnutrition, and you can make a decision there and then. If you don't want to use this, there's a simpler one called the malnutrition screening tool. Also pretty simple to use. You don't really need anything, no lab tests. You can do it straight in the clinic or in the hospital setting. The MST is more applicable to nursing homes, acute care setting, cancer patients. The difference between these two tools is the fact that with the M&A from Nestle, you can assess risk and diagnose malnutrition, but with the MST, you only assess risk. It will not diagnose malnutrition. So I would highly recommend the M&A. It's a pretty cool tool to use. Using anthropometrics. People come to our clinics, hospitals, we always take a height and a weight, and that's to help us get the BMI. In the old WHO says that if your BMI is 18.5, less than 18.5, you are underweight. But in using the BMI to assess the older adult, I think there are a few things we have to know. So for example, if you're 65 years or older, there is some mortality benefit if you're overweight. But if you are underweight and you are obese, the risk of dying is higher. So it's desirable that you're overweight. That is what the evidence says. Also, if you have a stable BMI, we prefer it to having changing BMI. So your BMI goes up, comes down, the risk of dying is higher. So if you're following your older adult in the clinic, the hospital, BMI stable, good. BMI going up, BMI coming down, not good. Also, in assessing BMI in the older adult, you have to know that osteoporosis is pretty common. You can have compression fractures in the vertebrae that can reduce your height. So probably what you get for BMI might not be truly reflective because the height might be lower or less. And also, other patients have CHF. They have peripheral edema, so that can add on to the weight and so throw the BMI up a little bit. So these are things we should kind of remember in using the BMI to judge nutritional status of the older adult. Also, if you lose 5% of your weight in 1 month, 10% in 6 months, your risk of dying or getting ill is higher. And if you lose that much weight, you're more likely to go to the hospital, or you're likely to develop some functional limitations. So it's kind of important to know how weight plays in the nutritional status of the older adult. How do we use nutritional intake to assess nutritional status? In the history, we just ask, how much are you eating? What are you eating? How often are you eating? That can help you know the nutritional intake. And there is such a thing as inadequate nutritional intake. And the definition here is your average intake of food, groups, nutrients or energy up to less than 50% below the threshold of the recommended daily allowance. If we go with this definition, up to 18% of people in nursing homes have inadequate nutritional intake. And it's amazing because it's not because in the nursing home the appetite, or in people who live in the community, the appetite is not there. The appetite is there, but the challenge is how do we get the food? And we'll talk more about this in the slides to come. Lab tests. We all know about albumin. Albumin is a fantastic marker for mortality, morbidity, but in assessing nutritional status, it is not a good gauge. The reason being that it's a negative phase acute reactant, so if you become very ill, your albumin goes down. If you have an older adult coming to the hospital, septic shock, pneumonia, very bad CHF. You check the albumin, it's going to be low because it's a negative phase acute reactant. So if you're going to use that to assess nutrition status, it's not good. Let's say they start getting better, they're eating okay. It takes 20 days for the albumin to reflect the improved nutritional status. In that regard, you could use prealbumin. Prealbumin is also an acute phase reactant, but the advantage with prealbumin is that it has a shorter half-life. So possibly about 4 days it changes. And I use this a lot in my ICU patients. They come in septic shock, whatever you can think of. Prealbumin is less than 7. On a MEC vent, we put an NG tube down them. I start feeding them Pulmocare Nepro. In about 6-7 days, the prealbumin starts to go up if I'm able to balance the nutritional intake with what they're burning to get better. It starts going up. So probably prealbumin might be a better marker for recovery compared to an albumin. Cholesterol. It's not good when you're young, but cholesterol probably will be good when you're older. So the thing is, if your cholesterol is low when you're older, your risk of dying is higher. And for persons who have pretty low cholesterol, you see less than 160 people who have cancer. So it's something to know. And for older adults who live in the community, if your cholesterol is low, your albumin is low, your risk of dying is way higher than if your cholesterol or albumin is low. So kind of important to remember this for the patient we see in the clinics as well. You could decide to use transferrin also as a gauge of the nutritional status of the older adult, but transferrin is a big function of your iron stores, can be affected by hepatic problems. Infections can also play a role. So I won't advise. So in all this, if there's ever a test you wanted to use, I think prealbumin might be the way to go. In talking about screening, I think it's important to know that alcohol limits absorption of the B vitamins. Antacids will limit B12 and iron because you need acidity to produce that complex of intrinsic factor with B12. You need acid to reduce iron so you can absorb it through your gastric mucosa. And then antibiotics limit vitamin K because you're killing off all your good bacteria, so you can't make vitamin K from gut flora. The digoxin limit total caloric intake because it makes you anorexic. The SSRIs limit total caloric intake because they're making you anorexic, so you're not eating like you're supposed to. Metformin can give you megaloblastic anemia because it's limiting absorption of vitamin B12. And Bactrim, pretty common, we use it for MRS, we use it for a lot of stuff. It can limit your folate and give you megaloblastic anemia as well. How do we address malnutrition? And like geriatrician, we always like to use a multidisciplinary approach. If it doesn't come up in a geriatric talk, you're not talking geriatrics. So I had to bring it in. So we use a multidisciplinary approach. And I think if you get a dietitian in your corner, it helps. So the dietitian can take that role of really assessing in depth how much the person is eating and help you come up with goals for recovery. Social worker can help you get resources, especially if it's socioeconomic factors predisposing the older adult to undernutrition. And family members, they can be a good layer of support. The important thing is not all patients are the same. So in coming up with a goal to address undernutrition, you have to individualize for your patient. It has to be individualized for the patients. Some interventions, patient-centered, can include maybe addressing the dentures which are not fitting okay so that they can chew well. That might solve it. Maybe it's about just changing the food consistency. Mechanical soft, pureed, maybe that's what would help. Maybe it's just about enhancing how the food looks like or changing how the presentation is, and that's all there is to it. Maybe it's about just being attentive to what the older adult is asking, what they want to eat, that's all. And like we said, you lose smell, you lose taste. Probably using herbs, they can tolerate spices or hot meals, these can compensate for the loss of smell and taste. But do not use more salt, more sugar, it does not help. If the patient has acute stroke and the goals of care are clear, they want aggressive measure, probably getting a speech language pathologist to help initially, and using feeding tube in the short term will help. And then maybe doing a thorough medication review, taking out all those medications they do not need can help boost their appetite. And then if there's any medical condition or psych problem we have to address, maybe that would help with improving the nutritional intake as well. In the nursing home, probably changing the setup of the eating area helps. So some nursing homes invest into maybe a cafeteria style, or maybe using a tray serving style or tray delivery. And then maybe assistant residents who need help with feeding helps. And there was this study out of Australia where for 2 years they said, well, we're going to get controls. We will not help them eat in their, when they go for dining, and then for people who need help, we'll help them eat. So the residents who were assisted with eating maintained their weight over 2 years compared to control. So in the nursing home, maybe assistant and residents who need help with eating helps. And then allow for leisurely eating. We don't have to rush the older adult. It's okay. And then sometimes placing 2 or more residents together so they can interact whilst they eat also helps increase food intake. For patients who live in the community, Meals on Wheels can help if they can't cook for themselves. And then for older adults who have like substance abuse problems, social isolation, getting them in touch with support groups can also help. And then family members, friends to help with shopping, getting them to and from the shopping mall, helping prepare meals can help. And then Active Generations has this fantastic daily congregate eating place here in Sioux Falls. And I've been there. It's a wonderful place. I see older adults, they talk, they eat. It's a wonderful place. So that is a good resource for some of our patients who are in the community as well. Nutrition supplements. The patients will ask you, Doc, do you think I need some type of nutritional supplements? So I think we should talk about it a little bit. So these contain both macro and micronutrients. And they can be either in a liquid form or bar form. But the choice of the patient depends on the cost, whether or not they can chew, and then maybe the flavoring they use for preparing these nutritional supplements. The literature says that about 60% of older adults somehow currently take over-the-counter dietary supplement. I think it's more. But I guess the downside to some of these nutritional supplements is they can maybe provide excess calcium, vitamin A, vitamin D. And as it stands right now, going through literature, the data is insufficient to say that these supplements are beneficial. How about using drugs or medications to treat undernutrition? There is no mortality benefit, and I think it's really a slippery slope. If you pulled the first 3 medications to look for the approved indications for them, they are approved for using. Their use is basically approved for patients with HIV and cancer-related anorexia, not in the older adult, not just anorexia in the older adult. So mirtazapine, if there is no concurrent depression, the evidence is 0 to use for anorexia in the older adult. It can cause drowsiness in over half of the patients. It can cause dry mouth in up to 1/4 of the patients. And dry mouth is a big deal in the older adult. So probably the risks more than the benefits with mirtazapine. Megace, increased risk of DVTs. It causes you to retain fluids. So if you have CHF, you can have CHF exacerbation as well. And if you gain weight on megace, it's just fat. Megace can also increase your risk of getting adrenal insufficiency because it will cause as a negative feedback loop and then cause your adrenals to atrophy. So something to consider. Dronabinol. About 3 weeks ago, I had a patient who was really restless and agitated and like, what is going on? People thought it was a UTI, killing her heads, doing CAT scan of the head. I just sat down and said, let me go through her meds. And she had been starting on dronabinol for anorexia about 5 days ago. We stopped it and she was okay. So dronabinol can exacerbate mania and schizophrenia. Dronabinol can cause euphoria in about 24% of the old adults, so kind of important to know. And cyproheptadine can cause confusion as well. With regards to nutritional syndromes, you would come across these two pretty common in the older adult. involuntary weight loss and obesity, so I just thought briefly talk about these ones as well. So involuntary weight loss, you're losing about 4.5 kilograms over 6 to 12 months. It's pretty common in the nursing homes. That's about 50%. And in hospital patients, up to about 25-50%. Way less in the outpatient setting. What can cause involuntary weight loss? 20% you cannot find a reason for it. 20% may be due to cancer. 10% maybe some psychosocial stuff going on. And then half of the time it can either be due to end-stage COPD, end-stage CHF, GI conditions, some medications, some neurodegenerative disease. But I think if there's anything to remember about involuntary weight loss here, remember that 20% of the time you cannot find a reason why they're just losing weight. And if you're losing weight, likely you're losing lean muscle mass. Remember that if you lose lean muscle mass, some of the risk can be poor wound healing, increased mortality, and we know that if you lose up to 20% of your weight, your humoral and cell-mediated immunity malfunctions and your risk of getting infections go high. How do we address involuntary weight loss? You have to have serial weights to document that the patient is losing this much weight over this period of time. Again, history, physical exam. If you have to, focus labs. And then if you ever find a cause, you treat the underlying cause. But remember, it's difficult. Up to 20%, you cannot find what's going on. How do we address it? If they are on any restriction, maybe for CHF, for diabetes, it might be time to say, well, maybe they do not need this. Let's limit this food intake. Let's do constant carb, or just let them eat a regular diet, see if that goes, because we know if they lose weight, their mortality goes up. So it might be better to take the restrictions off. You may consider nutritional supplements in between meals or multivitamin, but the data is not pretty robust. And it would help to have dietary education. By this, the dietitian goes to see the patient and says, these are the options we can have for you. You don't have to only eat this. You can eat this and eat that, and then the older adult has more options and is empowered to make more choices with regards to their food intake. And that can maybe boost the total caloric intake as well. Obesity, the same definition. The prevalence of obesity has increased. It doesn't matter whether you're a man or woman, black or white, whether you're majority or minority, prevalence has increased across the board. Obesity is associated with increased impaired functional status, increased mortality. And it's amazing that for an older adult living at home by themselves, compared to their male counterparts, they're more likely to be if they're obese, they're more likely to be deficient micronutritionally, and they're more likely to have food which is poor in quality. Why, I do not know, but just kind of something to think about. To treat obesity, I guess the biggest taking point is getting the older adult to a weight, it's not defined, where their health is improved, their function status improved, and the quality of life is good for them. That weight varies from person to person. So whatever weight they can get to where there's improved health, improved function, improved quality of life, that will be good for them. To achieve this goal, you have to look at their diet. It has to be a prudent diet. They have to know that we're doing this where I can get better, so behavior modification and increasing physical activity, you have to weigh carefully, because again, if you go too much, there's increased risk of injury, so you have to kind of balance that as well. There's such a thing as a frail older adult. In the frail older adult who's obese, you don't have to aim for weight reduction. Just aim for preserving strength in them. So, some things to consider. This is the tail end of the presentation. Important to know that ethnicity, religious background will influence the older adult's food preferences. And that for minority patients, there are resources available that are culturally sensitive. I grew up in West Africa. Some of the diet here is pretty different for me. I have people who come from Africa who are my patients, and they cannot maybe take the mashed potato, they can't take what is available in the nursing home. So there are resources online that can help, especially in the outpatient setting, where they can eat culturally sensitive food as well. And then from the medical legal standpoint, you have to offer food and fluids to all your patients. It doesn't matter whether in the ICU, in the acute care setting, you cannot deprive a patient of food and fluids. It's a basic right. If you decide to start or stop artificial nutrition, you have to weigh it carefully. Most lawsuits centering around nutrition normally is around somebody making a decision to start or stop artificial nutrition. So it's kind of important to know what the patient wants, the advance directives. You have to go to know what their wishes are. And as clinicians or as dietitians, we have to aim to honor advance directives. We don't have to treat the family. We don't have to treat ourselves. It's about the patient. So what do they want? If at the time they were competent, they said, this is my express wishes. If they get to that time where they're incapacitated, it doesn't matter what the wife says. It doesn't matter what the daughter says. It's the patient's express wish. That's what holds. Unless we can prove otherwise, that maybe if they were here right now, this is what they would have wanted other than what they've already stated. So kind of important. For patients who are deemed incapable of making medical decisions, or who are deemed incompetent and do not have advance directives, if there's a surrogate, we have to involve them early in this complex decision of starting or discontinuing nutrition. It can save us a lot of issues. And we'll reiterate again, there is no evidence to support the use of feeding tubes if the patient has end-stage cancer, end-stage dementia, or COPD. It does not help. Feeding tubes do not decrease your risk of aspiration. You can aspirate equally if it's a PEG tube or it's a nasogastric or oral gastric tube. You can aspirate as well. And if you should stop everything, water, nutrition, it might take several weeks for the patient to pass. So it's important to involve palliative care early, because sometimes that complex road of navigating, telling the family it's okay, there's something as natural dehydration that helps the death process, can be overwhelming. So getting palliative care early to help, can save you a trip to the court down the line. Thank you. So questions, comments?
Dr. Bechtelsbauer and I were talking. Dr. Lee is a premier geriatrician in the state and a guru in nursing homes, and we were discussing numbers of nursing homes. If you measure one nursing home, one parameter in the elderly, you ask the group, says, what is it? What is the most vital in the elders? It's weight. Weight is a very sensitive barometer of health. And if it changes, it's either disease, dementia, depression, drugs, or some social issue. They can't eat, they don't have the money, what you've given them is making them anorectic, or they're cancer, or the dementia is causing them anorectic, or they're depressed, and that also causes anorexia. So all those things, you have to be able to figure out why they are losing weight. And yes, everyone's scale is different, and when you tell people to weigh the patient, they'll fuss, because scales, well, then critically think, reweigh them. I go round and around and work on this one. You gotta, why is their weight changed? And it's one of these things. I guarantee you that. And so you really need to pick up on that. And as you said, the answer is multifactorial. All you medical students, whenever you talk to a geriatrician, the answer is always interdesk team or multifactorial. It is. A lot of things go into it. Think of when you don't eat well in a day. If if you look at a couple different days, it's a different reason each day. You don't like the food, you're too busy, you don't feel well, or something. And the elders are the same, so you got to really look at why they're not eating. It's sort of that multifactorial approach, and it's all these things I mentioned we rolled into it. You're in an assisted living, and they don't have a good cook on Sundays, and no one eats well that day. Okay, I hear about that every week. So it's really important to look at what their weight is, and why is it changing? Is it diuretics? There's a lot of reasons to make it change, but look at what their ideal weight is. And it can be something as simple as the dentures. I haven't heard that have someone bite your finger. Most of my vets, the VA, say, pull my finger, not can you bite my finger. I put gloves on.
Yes, for sure.
Yes. Alrighty, but their thing is, elders are slow. I mean, you guys can woof and huff 30 minutes for someone in an assisted living or a nursing home. My great uncle, his wife did better at home with him than a nursing home because he would take an hour to feed her with her advanced dementia. Every meal, he had such patience with her. She did better. And a lot of disease states, the bradykinesia, and it just takes a long time to eat. So take your time, enjoy it. You might be done in 10 minutes and it takes them 30, that's okay. Enjoy the time with your parents. A lot of little things go into it. What do they like? And sometimes you just have to help eat, get the proper utensils. Some people are pretty independent and don't want you to kind of go like that and cut their meat. That's, irritate me. And how do you deal with sort of the dementia and letting them and respecting them to get them to eat? So there's on my director's blog, one of the directors said, everyone has a bottle of Ensure in their VA nursing home. Can't we give them just good food they want to eat? The bottle of Ensure on every plate is the wrong answer. It really is. Why? Why do you need this? First give them good food, figure out how they can eat better, what's the process why they don't want to eat, and then they'll eat the real food. And then maybe they do need the Ensure, but that's, I would say, the minority. And kind of last comment you adjusted at the end. What is starving? Starving is withholding food from a hungry person. You get anorexia when you're sick. When was the last time you had the influenza or something? You didn't eat for a day. Well, probably a lot of different things, but after Thanksgiving, it's that stuffed fundus. It's about this big, or at least it feels that big. Well, if someone is sick, dying, or they have or they're ill, that is the feeling they have all the time. And we see loved ones saying, oh, they can't eat, they have to eat, they have to eat. And I say, well, how do you feel after Thanksgiving when you've just eaten this much food? That's how they feel right now. That's normal. And if you tell them to eat more and you're stuffing it down their throat, it may go down the wrong tube, and it makes them feel unpleasant, because they're already full. And so that's the physiology of illness and also of dying. You just lose that. And you tell patients and family members that they'll kind of understand that he's just picking at his food. And it's pleasure eating at this point, whatever they want. I don't care what they eat at that point. If they're enjoying it, that's fine. But it might only be this much. That's natural. There's not a lot we can do about that. You're right, the feeding tube doesn't prolong life. The American Geriatric Society, 10 things for America, don't put feeding tubes in demented elders. Does not improve quality of life, doesn't improve longevity.